So I'm going to discuss a little bit of left main multivessel CAD using physiology. That's important. So the problem in multivessel stenting has never been whether we should stent it or not. It's been where exactly and how many. That's the question. So there comes the physiology, the fractional flow reserve. Everybody's heard about it. It's a very reliable index to distinguish ischemia. It has a very great spatial resolution. So you have clearly demarcation whether it's hemodynamically important obstructions within the coronary arteries, and of course helps in guiding PCI. Do we need to do a routine FFR in multivessel disease? Will it result in better PCI? Will it alleviate symptoms, improve outcomes, save costs? That's all is very important. So FFR we know is a lesion-specific physiological index which determines the hemodynamic severity. It is measured at maximum hyperemia. That's very important that your hyperemia has to be good because many of us tend to underdose our adenosine when we give intracoronary. And we know that pressure is a surrogate for flow, so we have PD by PA that gives us the FFR. Because of its robust data, it has a class 1 indication almost everywhere, the ESCA, EATS guidelines. In fact, FFR and DS are the only two technological data which has this class 1A indication. Studies started with courage where we got this clear message that in patients with stable CAD, OMT may be equally good unless you need to have recurrent angina, then PCI and OMT. Differ showed us that stenting a non-ischemic lesion does not benefit the patient with stable CAD, so it's safe to defer patients with high FFRs. FAME told us that it is advantage to assess this multivessel disease, it improves the patient outcomes, reduces healthcare costs, and stent the ischemic lesions and leave the non-ischemic lesions alone. And generally, angio tends to overestimate lesions. FAME2 told us that FFR guided PCI is superior to OMT in stable patients very, very clearly. Then came RFR, which is similar to FFR, but the advantage is it's continuous, it happens in systole and diastole, and it takes the lowest PD by PA in either diastole or systole, so it's independent of the ECG, you don't have to worry, and it's very sensitive to small pressure full back, and it's been clinically validated very, very clearly. RFR is almost 94% accurate versus FFR using the RFR gray zone of 0.6 to 0.93. So it's very, very reproducible. I'm going to show you just simple examples. We'll have a lot of time to discuss if you want after that. So this is a very clear left main which angiography also looks significant. But the important thing here is how do we do it? How do you do the FFR here? So it's always important that as you attain maximum hyperemia, you have to disengage the guide. If you do not disengage the guide, you will end up with a faulty FFR reading and you may label it either both ways, either insignificant or significant. That's very, very important. Because there are many a times, as she just spoke about imaging, IVUS doesn't give you the answer every time. So if you have a borderline IVUS image, whether you want to stent or leave it and the ischemia is not very clear, then this really helps us. But the important thing is that you have to see that the guide comes out and you can equalize your wire in the cusp. So you don't have to enter the coronary to equalize the wire. Because many of us have this feeling that we'll have to enter into the coronary to equalize the cusp. You don't have to. You can always do it in the cusp. You don't have to enter the coronary. But important to remember is to disengage the catheter. Similarly, if you see this diagonal lesion at the LAD bifurcation, in olden days when we didn't use physiology, I'm sure we would have done a double stent here or at least a provisional stent into the LAD and maybe left a POBA to diagonal or left it alone. And this was the right coronary. The moment the RFR of LAD and diagonal came, both were negative. So these both could have been left alone. And this was the right. Similarly, this circumflex lesion was the culprit with, as per the ECG, but then you have the same problem with the LAD diagonal. The LAD here in the mid after the diagonal looked significant. Should we be stenting those LADs? Even CABG would be an option if you think that this lesion is significant. Again 0.87, 0.82 was left alone. Circumflex was done. Important in osteal lesions, you have to see that, as I told you, you start adenosine after you pass the pressure wire. Osteal lesions, please try to use intravenous, avoid using bolus adenosines because it's not going to get a proper response. You have to disengage the guide. Once you achieve hyperemia, always dislodge the guiding catheter carefully, and it's often best done by advancing the pressure wire ahead. During pullback, if you're not confident of holding the guide, you can hold someone to hold it. Interpretation of the FFR is just as usual. And remember that in ostial and left main lesions, only a minimal gradient is present at rest, which largely increases at hyperemia. So that you need to know that. So when you just pass the wire, you might not see any gradient because there's a large perfusion area involved. Hyperemia has to be intravenous in such lesions. Please do not use intracoronary in such lesions. So, important of physiology in complex multivessel disease is very, very important because we can stent, avoid too many stents. We all know more the number of stents, larger the length of stents, more is going to be the MACE rates. Do not use it in acute STEMI, but it is very clearly not been proven that is going to be correct in acute STEMI. It's better to wait for a few days before you measure FFR in a non-culprit vessel. The pressure pullback curve, I think, is one of the best things you can get in a multivessel disease. And this came from the modified syntax where they found that if you do relevant intervention, you do not go for absolute complete revascularization, because if you do complete revascularization, then you revascularize everything more than 50%. And in that trial, it was shown that if you revascularize more than 70% and leave the less than 70% alone, the outcomes were equal to complete revascularization. So relevant revascularization is important, whereas FFR will help you. You can achieve maximum hyperemia, and as you achieve maximum hyperemia, you do a slow pullback across all the lesions, and you might end up putting one stent of 3-4 because the length of the lesion decreases. So that's a very good tool in use. So pressure pullback reading is very important in osteal lesions, multivessel disease, left main lesions, tandem lesions, and diffuse disease. Thank you very much.